muito nos honra tê-lo aqui. Todos conhecem, ele dispensa apresentação, um dos principais nomes da terapia intensiva do mundo. E ele vai hoje nos fazer 3 apresentações. A primeira vai ser uma atualização em vasopressores, aproximadamente 40 a 45 minutos de duração, e depois outras 2 apresentações. Ao final de cada apresentação, quem quiser fazer perguntas ou discutir alguma coisa em especial, fique à vontade. So Daniel, it's a great pleasure to have you again. You are now, I think I can say that you are carioca now.
Not really, but I have my microphone. So thank you very much, Fabio, for the very kind introduction, and thank you for having the opportunity to be here in Rio again. And it's my great pleasure to be here and to discuss with you a couple of things on here for this first talk on the novelties on vasopressors, because indeed there have been a few important new data on vasopressors. And so in this talk I will combine a little bit what we know from, I will say, a long time. I will discuss what says guidelines, and then of course we will later on also discuss the new data and see whether or not we should jump on the new vasopressors that are proposed. Among the very important aspects that we have to realize is that indeed we can see that hypertension is something not very good for our patients, and it seems that indeed the hours spent with a low blood pressure here, defined as a blood pressure below 60 millimeter mercury, you can see that the longer the time spent with such a low blood pressure, the higher the mortality. Of course, this is one of the kind of data you can find, but you can find more and more data going in the same direction. Here, a huge database here in the US showing that indeed the mortality again increases quite a lot with time spent with blood pressure below 65. And you can see that it increased quite a lot. Some of the figures there seems to be sometimes a little bit surprising for many of us. I don't know exactly for yourself, but spending 24 hours or even 48 hours with a mean arterial pressure below 65 seems a little bit, let's say, unrealistic for me, because indeed the way we manage our patients in our ICU is that when we see some hypertension, we try to correct it. And being with a patient with 2 or 3 or even 4 days with mean arterial pressure below 65 will probably not be encountered in my ICU. So yes, indeed, for a couple of hours, and then the patient will be above it, and of course when he will die at some point, it will be below it, but then it will not last for such a long period of time. So I'm still surprised to see this kind of data, but nevertheless, given the fact that other people have different targets, obviously. It's quite interesting to realize that, again, you can spend several days with hypertension, and unfortunately, there is a risk that the mortality will increase in these conditions. So the literature is quite strong to say that indeed the longest the time spent with hypertension is associated with a poor outcome. And so it's not only the time, but also the severity. The lower the blood pressure, of course, the higher the mortality also in the same direction. So it sounds reasonable to try to correct this hypertension without real delay. And then we have to discuss, of course, what would be the agent we will use. And for this, we need to go back to the basics. And we have, of course, the adrenergic agents, we will discuss first, and the non-adrenergic agents. And we have much more data now for discussing these new agents there. So for the adrenergic agents, of course, we have dopamine, norepinephrine, epinephrine, and phenelphine. And the difference between these is really a little bit of the strength of the alpha receptor stimulation. And remember that it is because of the alpha stimulation that we have the vasopressor effect. But you have also, in conjunction with this, some stimulation of other receptors, and in particular, stimulation of beta receptor, and of course, just for dopamine, the dopaminergic receptor. But because of this stimulation, which is quite variable there will be additional effects. And of course, we expect, because of beta effect, to have a higher stimulation on the flow and the cardiac output. So theoretically, we would expect that epinephrine may perhaps be the best agent, because indeed you increase both mean arterial pressure and cardiac output in these conditions. But we will discuss that it may not be the case, because the problem is that the beta stimulation is not really balanced, meaning that we will have the dose that we will target based on blood pressure. So we will not really aim to have a low or high or very high beta stimulation. It will be going with the dose you give for targeting your blood pressure. And so it is really something uncontrolled. And in some cases, it will be a minimal beta stimulation, some cases a very high one. Looking in experimental conditions, it is clear that indeed comparing a beta, a strong beta like the blue one for epinephrine, very mild one with norepinephrine, or an absent one in green for phenylephrine, for the cardiac index we have exactly what we expect, meaning that there is a highest increase in cardiac index with epinephrine than with norepinephrine, and a decrease in cardiac index with phenylephrine. What is quite interesting already to realize here is that the time may not play in favor of this beta stimulation, because indeed, after some time, we do not see any difference here in the cardiac index with the epinephrine and norepinephrine, even though, nevertheless, it was a higher stimulation of beta with the epinephrine compared to phenylephrine, to norepinephrine. If we look at other aspects, contractility is similarly affected here. The effect on the ejection fraction is also similarly affected here, with again a negative impact with the pure alpha without anything else. However, the most interesting aspect is to look at the impact on heart rate, which is markedly increased with epinephrine compared to norepinephrine, and that indeed with time the differences even are much more pronounced. And of course, because we have an increase in heart rate and the same blood pressure, at the end, the energy spent by the heart is much higher with epinephrine compared to norepinephrine or phenylephrine. So we will have more or less the same effect, because the flow will be increased to the same proportion with both agents. The mean arterial pressure, of course, will be the same, because this is the design of that trial. But the price you pay in terms of energy expenditure for the heart will be much higher with epinephrine compared to other agents. And we need to pay attention to it. So do we have in patients differences in cardiac output? Well, it seems so, at least at initiation of dopamine or norepinephrine. You can see that the increase in cardiac index is higher with dopamine, which has a stronger beta compared to norepinephrine. However, after some time, you don't see anymore this kind of difference, because indeed, at some point, the cardiac index is exactly the same when you switch one agent to the other one. So it seems to be a very short-acting effect on cardiac output, and at the end, you don't see this difference there. Would it be exactly the same for other effects? We'll discuss this in a few minutes. Because when you look at the differences in terms of hemodynamics and other factors there, when we look at dopamine and norepinephrine, the interesting aspect is to realize that there is no major difference in cardiac output. However, when we look at some other aspects, we can see that perhaps having dopamine is not a very good thing, because indeed, in a retrospective way, dopamine administration was associated with an increased risk of death compared to no dopamine administration. And that's why indeed we conducted that trial, where indeed we exposed patients to have a very long period of time with either the dopamine or norepinephrine, which were computed to be really equivalent in terms of giving exactly the same increase in blood pressure, so that physicians at bedside could not really discriminate whether your patient was receiving one agent or the other agent. Of course, because dopamine is not as strong as norepinephrine, we have to add an open-label norepinephrine in addition to that. And what we observed is that there was no major difference in blood pressure between two groups. However, heart rate was much higher for almost 2 days within dopamine group compared to norepinephrine there. No difference in cardiac output. So this means that indeed we do not have beneficial effects for dopamine there, because indeed cardiac output was exactly the same with the two agents. And in terms of other indices, the same decrease in lactate levels. And when we looked at the outcome, if anything, we had a worse outcome with dopamine compared to norepinephrine. It was not significant because the p-value was only 0.07. But it was a trend which was quite significant, quite interesting there to realize or to notice. In patients with cardiac shock, indeed, it was not very good because norepinephrine was really better regarding outcome and significantly compared to dopamine. The trend was indeed in favor of norepinephrine in septic patients, but of course, it crossed the line, so it was not significant. When we looked at side effects, we realized that indeed there were much more arrhythmias with dopamine compared to norepinephrine, and so that indeed this was not a very good signal for dopamine. Other trials conducted at exactly the same time were yielding exactly the same results. You can see here that dopamine was associated with a non-significant increase in mortality compared to norepinephrine in septic shock patients. And also, there were much more arrhythmias with dopamine compared to norepinephrine in that trial. So if you aggregate several trials, it's not unexpected that we find that indeed norepinephrine is associated with a better outcome, and this was significant now in septic patients also compared to dopamine. But you may say, okay, these are very selected patients from trials, and maybe in real life it doesn't matter so much. Well, it may, because these are very interesting data yielded from United States, because indeed there was at some time some shortage of norepinephrine. And so what they did in that trial is to compare the proportion of patients receiving norepinephrine before, during the shortage period, and after it. And they looked at indeed there was an increase in the use of phenylephrine, an increase in the use of dopamine during that time also, and an increase in the use of vasopressin during that time. The most interesting aspect is that in the same hospital, during this 3 to 4 months period of time, there was an increase in the risk of death in this hospital that indeed was occurring during that shortage period. And of course, disappeared after. And so this really suggests that the norepinephrine is really the best vasopressor agent when we discuss adrenergic agents. And this is why, indeed, in conjunction with the interventional trials, the Surviving Sepsis campaign recommend indeed norepinephrine as a first choice vasopressor. And this is why, indeed, it's a strong recommendation for this aspect. The problem is, of course, when we will discuss the fact that we have to use high doses because our patient is not really responding well to vasopressors. And this may be associated with a poor outcome. And this is one of these trials showing that indeed, when you have to reach values of norepinephrine that are here above 0.75 microgram per kilogram per minute for several hours, there is indeed an increase here in the risk of death of these patients compared to patients treated with lower doses. Of course, it's difficult to know whether it is the agent, which is somewhat toxic at these kind of high doses, sorry for this, or whether, on the other hand, it's just reflecting the severity of these patients, because, of course, much more severe patients need to be treated with higher doses there. And this is still open debate, and nevertheless, we can indeed look at complications, and we can indeed realize that in patient receiving high doses, limbic or digital necrosis begins to be present in these kind of patients. Again, severity of disease versus dose of the agent, we do not know exactly. And some patients also suffer from bowel ischemia. So this is beginning to be significant at high doses and not present at low doses. So what should we do at the time? Should we continue with high doses of this agent, or should we try to have another agent? And what should we do there to prevent this or to limit the complications, let's say, associated with high doses of norepinephrine? Well, if we look back at the guidelines at this stage, it's a little bit confusing in my mind, because indeed we can either add vasopressin, and we will discuss the quality of this evidence, even though it's a weak here recommendation, and we can discuss this, or epinephrine, and this is also a weak recommendation with low quality of evidence. And this is something that I have real difficulties to understand. And admittedly, it was driven by some of our North American colleagues, but nevertheless, it's something I don't understand at all. Because indeed, we use an alpha-adrenergic agent, and we add or another alpha-adrenergic agent, and we hope that it will be better than having twice the dose of the first alpha-adrenergic agent. But you are still acting exactly on the same receptor. So we use exactly the same pharmacological principle to raise the blood pressure. So I don't see exactly why we should do this. And indeed, there is no reason why this alpha-adrenergic receptor stimulation would increase it more than just increasing the dose of norepinephrine. The only thing that we will have is that we will have a higher and uncalibrated stimulation of the other receptors, which are here the beta-adrenergic receptors. And obviously, we already have some other trials showing that it is not very good. Indeed, we already demonstrated that, oh, it could be good because you can see here a much higher cardiac index in these conditions. But of course, it was also with a higher tachycardia in these patients, and also higher increase in metabolic effects, because indeed, remember that the metabolic effects are really dose dependent, and when we use high doses, we will face these kind of issues. And this is why we indeed can see that epinephrine is associated with tachycardia in these patients, an increase in lactate levels in these conditions. Again, shown in several trials that indeed there is an increase in lactate levels there. Not only an increase in lactate levels, but also a decrease or a drop in blood pH in these patients, and also an impairment in splanchnic perfusion in these patients. So probably all these kind of things are not very good. And the impairment in splanchnic perfusion was repeatedly shown in several trials here when we show exactly the same aspect. And also in patients with cardiac shock, you can see that there's also this tachycardia associated with epinephrine, the impairment in lactate levels, the impairment in splanchnic perfusion, and even a worsening of urine output with epinephrine compared to norepinephrine. A more recent trial, again, in patients with a cardiac shock, and you can see that for the same blood pressure, of more or less the same cardiac output with epinephrine compared to norepinephrine, multicentric French trial. You have a higher heart rate here in patients with cardiac shock here, and the stroke volume is not better there. So what else? Well, again, lactate is higher in these conditions, and we say, okay, so what? You don't care about lactate? Okay, but then these are the most important data there from the trial, that indeed, refractory shock was much more frequent here, 37% with epinephrine compared to only, if I can say, 7% with norepinephrine here. And when we looked at other data, there was also an increase risk of arrhythmias here with epinephrine compared to norepinephrine, an increased use of extracorporeal life support, ECMO, in these patients because of these problems there. And the death rate, even though not significant because of small size, was 20% higher, absolute higher here in the epinephrine compared to norepinephrine. So this is not really something that seems to be really desired. Of course, I say that in septic shock, this may not be so obvious, and perhaps indeed, if you look here, at 90 days, there was no difference here. But remember that the primary outcome of that trial was the 28 days, and that we had at 28 days that trend that was not significant because of the small number of patients here. The trial was aborted due to low inclusion rate, but nevertheless, I mean, this trend here is not going in a good direction. So probably is not really the best thing to do, is that we should not probably give epinephrine in these conditions to our patients. So, because epinephrine seems not to be the best agent, what next? What should we use? So we have a choice between non-adrenergic vasopressors, and for this we have we say new vasopressors, but I mean these are, of course, on their way for a long period of time, because indeed angiotensin was there in the 60s, abundant for a while, and then a comeback 2 or 3 years ago. The same is true also for vasopressin, which has been there for a while, and again, 10 years ago it came back, especially with arginine vasopressin, but we have no new agents, and especially celepressin needs to be discussed there. What is exactly the interest of these agents? Well, the main interest is that they act on different receptors. Indeed, we can see that instead of stimulating the alpha receptor, vasopressin will stimulate the V1 receptor, or angiotensin will stimulate the angiotensin receptors. But beyond that, it's exactly the same pathways. It's exactly the same pathways by increasing G protein, increasing phospholipase C, which will increase the calcium mobilization from the sarcoplasmic reticulum and increasing indeed the intracellular calcium. It also stimulates the protein kinase C, which will open the voltage gate calcium channel, and so calcium will enter the cell here. But so at the end, it's exactly the same mechanism. It's just the difference is the receptors there. So is it relevant, yes or not? Yes, it is, because indeed we have sometimes problems with receptors sensitivity. This means that indeed we may have one of these receptors here, an example is the alpha-1, which will be a little bit downregulated, so that indeed you need a lot of stimulation there to get a little bit of increase in blood pressure. And then of course, switching to another one may at that time increase the blood pressure that was not feasible with high dose of an alpha-1. The also interesting aspect is that we have different disposition into the vascular system. And this can, of course, generate positive effects, but sometimes also, of course, negative effects, and we'll need, of course, to think at it. And also stimulation of other receptors. Of course, not the beta receptor, because of these are not adrenergic agents, but stimulation of V2 receptor can also have profound hemodynamic and other aspects that we need to discuss. And for angiotensin, we do not know exactly, but there are probably also some other aspects, not just, of course, the increase in blood pressure related to the angiotensin stimulation. So let's discuss first the vasopressin. And of course, vasopressin is an endogenous hormone, a non-peptide hormone that is indeed synthesized in the supraoptic and paraventricular nuclei and transported and stored in the posterior pituitary, where it is released in shock. And the problem is that we have an initial release of the stored vasopressin, and then of course we need to synthesize it and to bring it to this area and then to release it. And the problem will be that after some time the vasopressin levels may be, unfortunately, sometimes not high enough. What are exactly the effects of vasopressin? Well, vasopressin is able to vasoconstrict, as norepinephrine, by the way, arteries and veins. So it's not only on the arterial side, but also on the venous side that there will be some constriction of the vessels. Interestingly, also, it is again in both aspects here, and increasing the dose is associated with an increase in the pressures there in both aspects. It is the V1 receptor, not the V2 receptor, because indeed stimulation here of the V2 receptor is not associated with any change in blood pressure or any constriction on the venous side also. Interestingly also, there is a potentiation of the effect of the alpha-adrenergic agent. So this means that when you give vasopressin, you have here this effect, and that the impact of the norepinephrine is much higher when you have vasopressin than when you do not have vasopressin in this condition. So that indeed we have the combination that will be stronger than the effect of one agent or the other agent in isolation. The effect of vasopressin is, of course, vasoconstriction when there is a stimulation of the V1 receptor. But also stimulation of V2 receptor is quite interesting because indeed it is another pathway, adenylytic cyclase stimulation mostly, and it is an antidiuretic action that you know as the antidiuretic hormone, of course. But there are also some other effects, and not only, of course, the vasoconstriction, of course, mostly on vascular smooth muscle, but also on kidneys, but also we have to remember also on platelets. And so this will have already some impact on platelets activity. The V2 is also very active on the kidney, but also on the endothelium, leading to dilation by nitric oxide release, and also aggregation of platelets. And this is something we need to pay attention, especially when we discuss sepsis and the procoagulant state that we have to face in sepsis. The V3 receptor is mostly related to the release of ACTH in the brain. And at the end, we have also the octreotide receptor, which is, of course, not very important, but nevertheless, it can also lead to some vasodilation in these conditions. Interestingly, when we discuss the different vasopressors effects there, vasopressin is a mixture of V1 and V2, but much more potent on V1 than on V2. If we think at terlipressin, this agent has a much more pronounced effect on V1 than on V2 compared to vasopressin. And celepressin is a pure V1 without any effect on V2. So, I mentioned that there could be some vasopressin deficiency in septic shock. And there are several reasons for this. First, there is also the depletion of the stores that occurs. Second, there is also a decreased stimulation of the vasopressin release by impaired autonomic reflexes in sepsis, and also inhibition of the arterial stretch receptors that occurs in sepsis. And at the end, the vasopressin, even when stored, cannot always be released easily because indeed the high nitric oxide and especially the high norepinephrine levels inhibit somewhat the release of vasopressin locally. And so indeed, it has been demonstrated 15 years ago or 20 years ago now that indeed there is some decrease in vasopressin levels occurring in septic shock patients, and that by giving exogenous vasopressin, it is possible in this condition to restore the blood pressure of these patients. And so indeed, it seems that a relatively small dose of vasopressor is already able to normalize the vasopressin levels and to improve the blood pressure in these conditions. So vasopressin was tested mostly in that trial, the VAS trial, which indeed was giving us some interesting information showing that indeed there was no major difference in outcome. The p-value was not significant, but nevertheless, if anything, it was slightly better, this trend here, compared to norepinephrine. It was never worse, at least, even though never significant globally. in some predefined subgroup, it was shown to be different in the less severe patient, where indeed there was a significant improvement with vasopressin compared to norepinephrine. But perhaps a little bit counterintuitively, because indeed in the more severe patient, when you expect more effect of vasopressin, there was no effect there of vasopressin. In a kind of a confirmatory trial, the VANISH trial, there was no effect, unfortunately, of vasopressin. And if anything, I mean, the trend was in the other direction, with a better survival with norepinephrine compared to vasopressin. And interestingly, the doses of norepinephrine at randomization were exactly the doses of the low severity group in the VAST trial. So if you put the two trials together, of course, you understand that globally there will be no difference at all in survival there. But there is also no impairment in outcome. So we probably would find a niche of patients who may perhaps benefit from vasopressin. If we look at what are the other effects, of course, we can indeed decrease the dose of norepinephrine there. There could be some impact on urine output, but quite minimal, and perhaps some lower creatinine level here compared to the other one, but no real nephroprotective effect. But interestingly, again, we need again to look at the individual response. And there is quite obvious that some patients respond quite well to vasopressin, while some others do not respond well to vasopressin. You can see here that indeed, these patients here, you have to increase quite a lot norepinephrine here. These patients will also increase their lactate levels and have minimal changes in blood pressure, or if anything, it will decrease and not improve. And while patient responding to teriparatide, here will have a decrease in norepinephrine, lactate will be relatively stable, and blood pressure will increase in these conditions. So some patients respond to vasopressin, some not. How to identify these is very difficult. It's very difficult. In a multivariate analysis, they just say that, okay, being in a non-medical ICU, so surgical ICU is probably better to say that you respond to vasopressin there. Okay, you do not have really to select your patient for this, and still quite difficult to understand why. Also, lactate, the lower the lactate, the better the response. Oh, unfortunately, perhaps exactly the reverse we will try to have, but or expect, but unfortunately for us, the more severe the patient, the less likely your patient will respond to vasopressin also. And so at the end, when we look at the association with ICU mortality, is exactly what you expect also. The more severe, the higher the risk of death of these patients. So teriparatide is also quite interesting because the issue is that the half-life is quite long here. So we either give it as a bolus and repeat the bolus, or we give it as a continuous infusion, but we have, of course, we have that given the half-life to need that at the end have exactly the same dose over 24 hours. And you can find trials using either one or the other scheme to give it to their patients. And what they observed is that basically, in terms of blood pressure, you have exactly the same effects again, and that you have no real difference in lactate levels there. In terms of other outcomes, well, no difference here in mortality here. And in terms of side effects, the only difference was more digital ischemia with vasopressin derivatives compared to norepinephrine in these conditions. So if we look at the recent meta-analysis in JAMA, it's quite interesting to realize that, yes, because we have less beta stimulation, we have less atrial fibrillation with vasopressin added to catecholamines compared to solely catecholamines here. So it's indeed, we have less atrial fibrillation, and this is probably something that can be beneficial in these conditions. Regarding other aspects, probably we can have some improvement in the kidney function, because indeed there is a less requirement for renal replacement therapy, which is close to be significant, but not really. It was significant. It's a low risk of bias trials, but again, not a lot of patients here, and the effect was, let's say, diluted by many other trials, and so at the end, a trend there, but maybe not enough to say that there is definitively an effect on kidney function with vasopressors here. Digital ischemia, yes, all studies again, significant effect here that there is a, there is a twice the risk of, I was too rapid here, so twice the risk of digital ischemia with vasopressive derivatives compared to usual catecholamines in these conditions. So we need to take this into account when we prescribe vasopressin in our patients. When we look at 28 days or 30 days mortality, there was a signal there, a signal that was considered to be significant when all trials were taken into account. However, we have to be quite careful, because when we just look at the low risk of bias trial, this effect is totally lost. I mean, really no effect here. And most of the effect on outcome was driven by the high risk of bias trials, so that indeed an aggregation of a lot of small trials was indeed driving the effect into a positive effect. So probably we cannot really state that there is a beneficial effect, but what is sure, there is also no detrimental effect. And the sole thing we need to think at, there is a high risk of digital ischemia with vasopressin. So what we consider now is that indeed we keep vasopressin as a second agent, not a first line, because of risk of ischemia, digital ischemia, and so on. And that indeed, in patient is not responding to norepinephrine, then we add vasopressin as a second agent. Being teripressin, vasopressin, I think we do not have strong data to say that one is better than the other one. Could celepressin be better? I mean, celepressin is really a pure V1 receptor, and indeed, just you can see that a relatively short half-life, and again, just a very selective alpha V1 receptor, sorry, and that the interest compared to vasopressin is that there is no antidiuretic effect, so that indeed there is an increase in urine output, but without indeed retaining water because of the antidiuretic effect associated with arginine vasopressin, which is not present with this agent here. In a phase 2 trial, there were some beneficial effects of celepressin. Most patients indeed responded to the high dose here. And with the high dose also, it was quite obvious that the cumulative fluid balance was much lower compared to norepinephrine in these patients. And this was something that sounds attractive and confirming experimental data showing that indeed fluid balance may be improved by celepressin compared to usual catecholamines or vasopressin. Unfortunately, and we do not have yet the data because it's not yet published, but these were presented last year at Brussels, there is no superiority of celepressin over norepinephrine. So, because indeed it was driven by ferrin, we do not know exactly whether or not this drug will be commercialized or not. Probably they expected to have a much more interesting drug to sell at higher cost probably at that time. So because of the absence of superiority, maybe it will not be developed or available. We don't know exactly. We have to expect the data anyway to see what will be behind it. Angiotensin. Angiotensin is quite interesting because, of course, as we mentioned initially, this drug disappeared from the market, even though it was present in the 60s. And it was driven by a new company bringing back this agent. And then some trials were done showing that indeed using angiotensin, it is feasible to decrease the dose of norepinephrine to reach exactly the same blood pressure when you give angiotensin in these conditions. And then there was this trial that is called by the FDA to be a phase 3 trial, showing that indeed for the primary endpoint, angiotensin was indeed able to increase the blood pressure at 3 hours in 70% of the cases, while in the control group it was only 20% of the cases. So a really very strong effect there. For the secondary endpoint, an improvement in cardiovascular SOFA score, but without changes in the total SOFA score, and of course a decrease in norepinephrine dosage with no impact on mortality. Perhaps, if anything, maybe a slightly lower mortality with angiotensin compared to norepinephrine, but we need to look at the numbers again, 160 in each group, so a very small size trial. Then we indeed can see that angiotensin was able to increase blood pressure much more than norepinephrine in that trial. The problem is that is really angiotensin more potent than norepinephrine? Or in other words, just increasing norepinephrine would have given the same aspect or not? Well, we need to really look at the data in very in depth. And remember that the primary endpoint, what was it exactly? So it was reaching a mean arterial pressure at hour 3 with a level of 75 millimeters mercury or higher. Okay, without, of course, increasing the usual vasopressor at the same time. So we need to have indeed to look at the data, and the initial mean arterial pressure was 65. In one group, we have no change in open label vasopressors. In the other one, we give angiotensin that we target to have or to reach mean arterial pressure of 75 and no change in open label vasopressors. Nice design. Which agent do you expect to reach 75 millimeters mercury at 3 hours? Yeah, of course. Not the placebo, of course, because you don't change anything there. So the design was made indeed to show that vasopressin is effective. But that's all we know. Vasopressin can increase blood pressure, but maybe other just increasing dose of norepinephrine would have exactly give the same results. So what does it do beyond increasing mean arterial pressure? Well, if we look at some other data here, we can see that compared to norepinephrine, which was a placebo here, or a mixture of norepinephrine and vasopressin, to be fair, there was no difference here in 20-40 patients in cardiac output or in urine output, and there was no difference in anything there between two groups, when indeed blood pressure was exactly the same in the two groups here also. When we look at the other aspect, it's quite interesting to realize that indeed there was a decrease in SOFA score, cardiovascular SOFA score. But remember that norepinephrine doses are included in the computation of the SOFA score. So by decreasing the norepinephrine dose, you improve the cardiovascular SOFA score. But interestingly also, there was no change in total SOFA score. This means that if you have decreased by 1 point here in one of the parts, you have an increase in counterpart here in the other component. So there could have been some increase in some other parts there that is missed, of course, in the total SOFA score. This was quite interesting because this was a secondary analysis of the same paper, focusing on patients on renal replacement therapy at time of randomization and exclusion, of course, if end-stage renal disease was present. Of course, because it was randomized in that subgroup of patients, we end up by imbalance because there were 60 patients in placebo and only 45 here. There was no stratification to begin with. And what's observed is that, quite interesting here, if we look at the survival rate, it was much higher in the angiotensin group compared to the norepinephrine vasopressin group. So maybe there a very strong signal that these patients may benefit more. And if they looked also at separation or recovery from renal replacement therapy or recovery from renal function, it was much more rapid and much more pronounced in the angiotensin group compared to the other group. Interesting, perhaps, especially if we think at the impact of angiotensin inhibitors on the kidney function. Of course, what they also looked at differences in patients at baseline, and there was no difference in blood arterial pressure, in age, PGT score, and so on and so on. There were some small differences in some other factors, and especially in the baseline angiotensin ratio, which is perhaps something a little bit troublesome. Also, the liver function was probably worse in patients here in placebo compared to the other one. And RDS was also more frequent in these patients compared to the other group. So when they make some computation to try to indeed adapt to the different factors, when they just took into account age, Apache-2 score, and so on, the benefit remained. However, when they also adapted to this liver dysfunction and the other factors like the RDS and so on, then there was no more any effect of angiotensin beneficial effect on outcome when they adapted it to that aspect. Perhaps still, the impact for renal function still remains valid, even for adapting for the imbalance into the, so maybe there is a signal for the kidney, but perhaps not for the outcome itself. Some warning signals. Well, interestingly, when you look at the electronic supplement, you always have to look at the electronic supplement of many of these papers. Then it's interesting to realize that angiotensin was associated with tachycardia. Angiotensin is associated with tachycardia. And so perhaps, again, something that may not perhaps be so good as we think, because it's exactly, if you look at the difference here compared to the placebo, you can see that exactly what you observe with dopamine compared to norepinephrine. Exactly the same magnitude, from 95 something to 100 something, from 95 something to 100 something. Exactly the same difference there. And so perhaps this is something that may be perhaps dangerous for patients, and we need to look at it. Also, if you look at some other adverse effects, and especially infections, later on, it was much more frequent in angiotensin compared to placebo. And this was again significant. So perhaps also the more recurrence of septic shock compared to that group. So maybe there could be some immunosuppressive effect with angiotensin, and we need really to look at it in future. And at the end, remember that even though FDA calls this as a phase 3, it was just looking at the impact on blood pressure. So it's probably much closer to a phase 2 than phase 3. And remember that previously, a phase 2 trial with nitric oxide inhibition was totally positive. And that the phase 3 trial that came later on just show exactly the reverse, with an impairment in outcome with this new agent at that time, that by the way disappeared from the market at that time compared to the other one. So we have to be quite cautious with this data at this stage. And so we can say that indeed norepinephrine remains the first choice agent. If one drug is of limited efficacy, it seems to be quite wise to add a second agent rather from another class rather than another agent from the same class. We need indeed to target different receptors to try to improve the sensitivity to our agents. Vasopressin is definitively a safe alternative. Angiotensin is promising, but in my mind, we really need much more data before jumping and using angiotensin at this stage. For this, I thank you for your attention.
Alguma pergunta para o Dr. Debaquet?
Daniel, thank you for a great presentation. Sometimes we're concerned about cardiac output before initiating vasopressin. We have a patient in the unit now that norepinephrine was going up, but she had a low normal cardiac output, and we wanted to start vasopressin. What do you do? Do you add inotropes? Do you monitor?
Well, it's an excellent question, and we are indeed concerned that in low cardiac output states, vasopressin derivatives may even worsen the cardiac output in these conditions. And what we try to do is not to give vasopressin in these conditions. So either you are able indeed with some inotropic stimulation to improve somewhat cardiac output, or we try not to use vasopressin because indeed, especially with telepressin that you maybe control a little bit less in terms of vasopressor effect compared to vasopressin itself, and especially because the half-life is much longer, you don't want to really give this agent to this kind of patient with borderline cardiac output. And I think that some of these effects of digital ischemia or necrosis may perhaps be related to the fact that they didn't measure cardiac output and they faced low cardiac output patients that indeed dropped their cardiac output just after. But it's a supposition.
Daniel, do you think there is any special scenario that we could use the dopamine as first choice nowadays?
I don't think so. I don't think so. And I think that if we are facing even the patient with bradycardia, I think that it's much wiser to give a small dose of beta, whatever it is. I mean, probably isoproterenol will be the best one, just to titrate to have the heart rate you wish to have and not go over that level, and then to use indeed norepinephrine to go for the blood pressure target. But I think that all in one, trying to push on one hand the beta and on the other hand the alpha is probably not the best one, because it's probably better to really fine-tune the dose of each of the stimulations.
Do you believe that one of these kind of agents could be restore the damage caused by the shock situations or septic shock in terms of disruption of epithelial barrier and epithelial dysfunctions such as capillary leak syndrome? One of them could be restore this. You know, some studies recent in preclinical studies about use of new agents that could be avoid this kind of damage, because hypotension is I think that hypotension is a harbinger of something wrong with the microcirculation. Mm-hmm. So I think recently we don't have to focus on vasoactive agents. We have to focus on which kind of agent could be avoid the capillary leak syndrome in the early stage of the shock situation. What do you think about this?
Well, I think that we are not yet at that stage. If you just think at the beta stimulation is normally one of the ways to somewhat counteract the increase in vascular permeability. But if we are in the phase of sepsis, given what we already have as a beta stimulation, I guess that this mechanism is not working anymore at that stage. So we need to go for other mechanism. In my mind, the best agent that was ever on the market was activated protein C, who was indeed acting on that aspect, and in particular was acting on SP1, which is one of these factors that indeed helps to maintain the endothelial permeability, and it has been shown that indeed activated protein C was acting on that. But we know that activated protein C is not on the market anymore, so we have to find something else. Adrenomodulin modulation seems to be one of the potential factors there. At least from experimental data, it seems to be promising. But at this stage, adrenomodulin is still in the the experimental lab. We do not really have clinical data to say that we can use this agent or not, and what could be the effects there. Beyond that, I don't see so many other agents really acting on the endothelial layer and limiting the capillary leak. I don't know which one you had in your mind. Some other one?
Mais alguma pergunta? Então vamos ter 5 minutos, rigorosamente 5 minutos de intervalo para tomar um cafezinho e voltar para as outras 2 apresentações que serão menores.